Pediatric Surgery Part 3 Intussusception Definition Telescoping of a segment of bowel intussusceptum into the adjacent segment, which is the intussuscipient. Incidence: the commonest cause of intestinal obstruction in children between 6 months and 2 years. The ratio of males to females is 3 to 2. The peak age is in infants from 5 to 9 months of age. 80% of patients are less than or younger than 2 years old. Types: we have ileocolic, ileoileal, ileocolic, and colocolic. Ileocolic: this is the most common type, intussusception of the terminal ileum into the right colon. Any infant having colicky abdominal pains with the passage of blood-stained mucus per rectum suspect having intussusception. Etiology: idiopathic in 95% of cases, adenovirus infections, mechanical factors, and post-operative intussusception. Adenovirus infections evidence: in most cases, hypertrophied Paris patches are noted on the leading edge of the bowel. The diseases is most common in midsummer and midwinter. Mechanical factors such as mucous diverticulum, polyps, hemangioma, enteric duplication, intramural hematoma, Henoch-Schönlein purpura, and intestinal lymphoma. Post-operative intussusception can occur at any age. Site is usually ileoileal or jejunal. Causes: differential return of bowel motility, often after retroperitoneal surgery. Clinical picture: type of the patient: well-nourished infants at the age of 3 to 12 months. This is the age of weaning. Symptoms: abdominal pain, vomiting, current jelly stool. Abdominal pain: awakens from sleep by severe abdominal colics, screams, and drawing his knees up onto the abdomen. The pain occurs in episodes which last for about 1 minute, alternating with intervals of apparent well-being healthy child asking for food. Vomiting in 85% of cases. Early reflex vomiting from pain, but vomiting later is due to bowel obstruction. Current jelly stool: it passes per rectum, mucus, and blood from venous infarction. Complications: prolonged intussusception leads to edema and hemorrhagic or ischemic infarction of the intussusceptum, which then leads to gangrene. Signs: general, pallor and sweating, common during colic. Progressive dehydration from repeated vomiting and obstruction. Local: we have a sausage-shaped mass, usually palpable along the distribution of the colon, most commonly in the right upper quadrant of the abdomen. Sign de Dance: emptiness in the right iliac fossa. Distension is usually absent in early cases, but if it occurs, it denotes possible perforation or gangrene. Direct rectal examination: it reveals bloody mucus in 60% of cases, and sometimes the head of intussusception can be felt. Investigations: ultrasound examination, barium enema, diagnostic and therapeutic in 60 to 80% of cases. Indications: in cases of doubtful diagnosis, it shows claw sign, which is characteristic. The barium will fill the colon and stops at the area of intussusception, and a cylindrical filling defect appears with a trace of barium on either side. CBC shows anemia. Treatment: preoperative resuscitation, IV infusion of dextrose and saline, antibiotics are prescribed, a nasogastric tube is inserted. Hydrostatic reduction. Indications in early cases, prerequisites: resuscitated patient, and methods: using contrast enema, whether barium or air. If barium is used, the colon of contrast shouldn't stand more than 100 centimeters above the patient to minimize the risk of perforation. Air is pumped into the colon at a pressure of 60 to 80 mm mercury. It means never more than 120 mm mercury. Success of reduction is confirmed by three things: free flow of barium into the small intestine for more than 5 centimeters, prompt clinical improvement with no further colics. The baby should be kept under observation for 24 hours. Success rate is 75% to 95%. Contraindications: doubtful diagnosis, late cases. And there is abdominal distension or rigidity. This means suspected peritonitis. The proximal ileum should never be pulled backwards to avoid intestinal tears. If intussusception is irreducible or gangrenous, bowel resection and anastomosis should be performed. Surgery. Indications: hydrostatic reduction, failure, or presence of perforation or peritonitis from the start. Procedure: squeeze method at laparotomy, The head of the intussusception is squeezed backwards out of the containing colon. Prognosis: mortality is high in gangrenous cases and recurrence in 2% of cases. Necrotizing enterocolitis, instance, increasing due to the therapeutic advancement in neonatal ICU. This allows more premature smaller babies to survive. 80% occur in premature infants weighing less than 2,500 grams at birth, and 50% are less than 1,500 grams. May also occur in full-term infants. Pneumatosis may be noted on gross examination and on plain abdominal radiographs. Pathology: necrosis, ulceration, and sloughing of intestinal mucosa. This leads to progression to full thickness necrosis and perforation. Gas-producing bacteria in the intestinal wall leads to pneumatosis. Clinical picture: symptoms: bilious vomiting, abdominal distension, bloody stools. Signs: general, lethargy, and poor skin perfusion. Local: abdominal distension and fixed loops of intestine. Guarding when intestinal perforation occurs but not obvious in weak premature infants. Abdominal wall erythema, edema, and crepitus in case of bowel necrosis. Investigations: radiological, plain X-ray, and paracentesis. Plain X-ray, position, supine and cross-table lateral abdominal, showing early small bowel distension, later pneumatosis intestinalis. Gas within the portal venous system can be seen but is fleeting. Serial examinations may show a loop or loops of bowel which are fixed in position and dilated. Paracentesis indications: infants who develop ascites without pneumoperitoneum. Examine the fluid for bacteria, and this signifies perforation. Laboratory: nonspecific, since the white blood cell count may be low or high, with perforation and sepsis, thrombocytopenia, and acidosis. Perforation with peritoneal air develops in 20% of cases. Contrast studies are hazardous and contraindicated because they may lead to perforation. Rarely, primary anastomosis is safe. Intestinal stricture may occur as a late complication following healing, so contrast enema is used to evaluate the defunctionalized distal bowel before closure of the stoma. Treatment: medical and operation. Medical: orogastric suction, stop feedings, systemic antibiotics, correct hypoxemia, hypovolemia, acidosis, and electrolyte imbalance. Operation: the only absolute indication is pneumoperitoneum. Procedure: laparotomy, resect necrotic bowel, the proximal bowel is made into a stoma. Complications: severe diseases, extensive bowel resection, then short bowel syndrome. Bedside drainage of the peritoneal cavity. Indications: in very low birth weight infants weighing less than 1,500 grams, it's gaining acceptance for documented perforation. Methods: in the right lower quadrant using local anesthesia. Prognosis: third of cases resolve without further treatment. The overall survival rate is more than 50%. Gastrochiasis definition: it's a defect in the abdominal wall which usually occurs to the right of normal insertion of the umbilical cord. Incidence: twice as common as omphalocele, and the defect is usually smaller. Clinical picture: the small and large bowel, stomach, and often the fallopian tube ovarictitis herniate through the abdominal wall defects. Liver is never present in the defect, unlike omphalocele. The bowel wall is edematous and has a very thick, shaggy membrane, peel, covering as it passed in the amniotic fluid and compressing the mesenteric blood supply at the abdominal defect. The loops of intestine are usually matted together, and the intestine appears to be abnormally short. Treatment: urgent repair is necessary, unlike omphalocele. Small defects closed primarily after manually stretching the abdominal cavity. A staged approach is frequently required using a silo, described with omphalocele. It's believed to arise at the site of involution of the right umbilical vein. Complications: since the bowel hasn't been contained intra-abdominally, the abdominal cavity fails to enlarge. This means that it cannot accommodate the protuberant bowel. Liver and biliary tract disorders. Jaundice in the first 2 weeks of infancy is usually due to indirect, unconjugated hyperbilirubinemia. The causes include physiological jaundice, Rh, ABO, and rare blood group incompatibilities and infections. Physiological jaundice due to immaturity of hepatic function, and this is associated with breastfeeding, while the incompatibilities produce hemolysis. Infections, jaundice which persists beyond the first 2 weeks in which the indirect and direct bilirubin levels are elevated. This means potential surgical disorders such as biliary atresia, which is the most frequent 60% of cases, various forms of hepatitis in 35% of cases, and choledochal cysts is found in 5% of cases. Mild indirect hyperbilirubinemia occurs with pyloric stenosis and disappears after pyloromyotomy. Intestinal obstruction can intensify jaundice by increasing the enterohepatic circulation of bilirubin. Jaundice is an early and important sign of septicemia in the newborns. Biliary atresia. Definition: it's the absence of patent bile ducts draining the liver. Incidence: 1 per 10,000 live births. Etiology: unknown, but may be due to inflammatory process which leads to occlusion of variable length of biliary tree. Congenital onset due to familial cases and frequent association with the polysplenia syndrome. Pathology: the atretic ducts consist of solid fibrous cords which may contain occasional islands of biliary epithelium. Liver biopsy: proliferation of the bile canaliculi containing inspissated bile, and this leads to failure of excretion of the bile out of the liver, leading to progressive periportal fibrosis and obstruction of the intrahepatic portal veins, and finally, it leads to biliary cirrhosis. Types: type 1, 2, and 3. 1. Obstruction at the level of common bile duct. 2. At the level of common hepatic duct. 3. Unfortunately, 90% of cases are type 3. Non-correctable: the extrahepatic portion of the biliary tract is occluded and appears as a cord-like structure. Biliary atresia probably develops after birth because jaundice is not remarkable in the newborn period but evident in older than 2 weeks. Conjugated bilirubin is not cleared by the placenta, unlike unconjugated bilirubin, and jaundice due to conjugated hyperbilirubinemia with biliary obstruction hasn't been recognized in newborn infants. Clinical picture: jaundice is noted at 2 to 3 weeks of age. The urine may be dark, stools may be normal or clay-colored and may contain increased quantity of fat, but they are of normal consistency and not frothy. The liver, early, may be of normal size, while later it becomes enlarged. Progressive cirrhosis leads to hard liver. Splenomegaly usually develops. Investigations: laboratory, CBC, metabolic and serological screening, and finally, liver function tests. The direct bilirubin levels exceed 3 mg per deciliters. Alkaline phosphatase levels are often elevated to 500 or 1000 units per liter. Glutamyl transpeptidase levels are more than 300 units. Radiological ultrasonography, it shows absence or inability to visualize a contracted gallbladder. Radionuclide scanning, HIDA, using technetium-99m labeled aminodictate diacetate compounds to observe the intensity of uptake within the liver and evidence of secretion into the bowel, usually preceded by 2 to 3 day course of phenobarbital to promote tracer uptake. Needle biopsy of the liver performed at any age if the clotting tests are normal. Differential diagnosis: choledochal cysts, identified by presence of a palpable mass in the right upper quadrant, and ultrasonographic confirmation. Inspissated bile syndrome, this is another differential diagnosis, and it's due to hemolytic process. A large bilirubin load is excreted in the bile ducts, and it becomes coalesced and impacted after a prolonged period of bowel rest with TPN, and it's recognized by abdominal ultrasound. The third differential diagnosis is hepatitis, most commonly of unknown cause, may be due to a variety of infections of maternal origin such as toxoplasmosis, cytomegalovirus, rubella syndrome, herpes simplex, Coxsackie virus, and varicella. Serum should be tested for elevated antibody titers to these agents. Genetic metabolic diseases and neonatal physiological jaundice, they are the rest differential diagnosis. For the genetic metabolic diseases, they include antitrypsin deficiency, galactosemia, cystic fibrosis. Other rare causes include sepsis, parenteral alimentation, cholestasis, Gilbert's disease, and Alagille's syndrome. Neonatal physiological jaundice is self-limited and response to phototherapy. Treatment: surgical exploration, timing as early as possible in infancy when the biliary atresia is a likely cause. Delayed treatment leads to progressive cirrhosis. Cholangiography is performed by cannulation of the gallbladder through a transverse abdominal incision or by laparoscopy, and gentle instillation of a water-soluble contrast agent. In the rare correctable type, hepaticojejunostomy is performed. Confirmed biliary atresia requires hepatic portoenterostomy Kasai procedure. The scarred bile ducts and gallbladder are removed. A row on Y limb of the jejunum is sutured to an area of the hilum bounded laterally by the hepatic artery branches. If this fails or the child develops significant complications of chronic liver disease, liver transplantation will be required. Choledochal cyst definition: it's a dilatation or diverticulum of all or a portion of the common bile duct. The etiology is unknown. Incidence: there is a female predominance 3:1, more common in Asians, with large majority of the reported cases from Japan. Types: type 1, 2, 3, 4, 5. 1. Fusiform dilatation of the extrahepatic bile duct. 2. Saccular outpouching of the common bile duct. 3. Referred to as choledococele, which is wide mouth dilatation of the common bile duct at its confluence with the duodenum. 4. Cystic dilatation of both intra and extrahepatic bile ducts. 5. Consisting of lakes of multiple intrahepatic cysts with no extrahepatic component. When associated with hepatic fibrosis, it's termed Caroli's disease. Clinical picture: type of the patient: the majority of cases are in childhood before 10 years of age. Symptoms and signs: recurrent abdominal pain, episodic jaundice, right upper quadrant mass. As the child grows older, the cyst may become infected, leading to painful and recurrent attacks of pyrexia. Perforation of cyst leads to bile peritonitis, which is rare. If left untreated, it causes cholangitis and cholangiocarcinoma. The diagnosis is most often established by the clinical presentation and abdominal ultrasound. Investigations: technetium TC99M labeled HIDA scan, CT and MRI scans, endoscopic retrograde cholangiopancreatography ARCP, operative cholangiography, ultrasonography, and this is responsible for detecting of choledochal cysts in the fetus. Treatment: it should be excised and hepaticojejunostomy is performed. Anomalies of the gallbladder: absence of the gallbladder, rare, in 0.03% of cases. The Phrygian cap, in 2 to 6%, kinking of the fundus of the gallbladder, and it's of no clinical significance. Double gallbladder in 1 in each 4,000 cases with 2 separate cavities and cystic ducts. Floating gallbladder: it hangs on the mesentery, liable to undergo torsion. Left-sided gallbladder, extremely rare. An intrahepatic gallbladder associated with increased incidence of gallstones. Cystic duct anomalies: absence of the cystic duct. Injury of the common bile duct is liable to occur when the cholecystectomy is performed in this patient. Low insertion of the cystic duct: it's common. The cystic duct opens into the common duct near the ampulla, and it may lead to ligation of the common bile duct during a cholecystectomy operation. The cystic duct may enter the right hepatic duct. Right hepatic duct may be mistaken for the cystic duct and ligated. Anomalies of the hepatic and cystic arteries: accessory cystic artery, this is the most common, may be torn if it's not identified. A large accessory left hepatic artery in about 5% of people. It may arise from the left gastric artery. The right hepatic artery may arise from the superior mesenteric artery, or the right hepatic artery pass in front of or behind the common hepatic duct or common bile duct and may be mistaken for the cystic artery, and it would be ligated. And this concludes the pediatric surgery as a whole of the pediatric surgery.